Now I would like to call Dr. Arif Mumtaz, Associate Professor, DHQ Teaching Hospital, Cohort, for his topic on acute heart failure, key take-home notes for acute physician.
Assalamu alaikum. Okay. So I will directly start because the time is. अच्छा कल से मैं नोट कर रहा हूँ ये वाली घड़ी ज़रा हमारी घड़ियों से तेज चल रही है. So acute heart failure. Actually, what is heart failure? A condition in which the heart, the pump which is in the body and it pumps blood to whole body is failed and it doesn't meet the metabolic needs of the body. So it can't pump so much of the blood. And acute heart failure can present as a new onset, which is 30%. Most of the people are having actually pre-existing some heart condition going on and they present with acute heart failure. So 70% of the patients which present to you with acute heart failure are already having some previously heart condition going on. And chronic heart failure, if we see that there is a cause and then there is the chronic remodeling of the heart leading to the negative remodeling, and then this patient can present with any cardiac type of cardiac injury in the form of metabolic drugs or stopping the drugs or any other arrhythmias leading to congestion, and then the immune system going on leading to stress on the heart and the mortality. So looking at the pathophysiology, there, if you look at the normal, so normally there is a balance between the pulmonary systemic vessels and the pulmonary vessels. The pressure is almost 10 to 15 millimeter of mercury in the pulmonary vasculature. Then initially which start is the hemodynamic congestion. The pulmonary pressure increases. So when it reaches 25 millimeter of mercury at rest or 30 millimeter of mercury with exercise, then the hemodynamic congestion. And then this patient present with the pulmonary congestion, the clinical features which occur with acute heart failure. Normally, if somebody is having pre-existing heart disease and he develops acute heart failure on the pre-existing heart disease, so the pulmonary congestion leading to the clinical congestion, the clinical patient presenting with the shortness of breath, edema and raised UP, which we see in the patient with heart failure, that takes 15 to 30 days. I'm not talking about the one which the patient has just presented with MI and developed acute heart failure. I'm talking about the patients who are already having some heart conditions and they developed acute heart failure. So triggering factors, because already I said that 70% of the patients are having some heart conditions. Maybe the patient is having chronic cardiac failure. So the most common cause is non-adherence. All of the physicians would have seen the patients who have been treated as chronic congestive cardiac failure and they had been treated, when they again present to you in the emergency, when you ask about, take the history, they say that we were really very well. So they will be saying that we were doing well with the treatment we had been on, but when we felt better, then we stopped the medications. And after a few months, they again present with heart failure and pulmonary edema to the emergency. Other causes will be acute coronary syndromes, arrhythmias, excessive rise in the blood pressure, infections. Yes, second common cause, if the patient is already with stable heart failure and he develops and he is compliant with the medications, the most common cause would be infection when he present to you with acute heart failure. Then toxic substances, drugs. There are a lot of drugs which can precipitate the heart failure, like the most commonly used non-steroidal anti-inflammatory drugs. Exacerbation of chronic obstructive pulmonary disease, pulmonary embolisms, surgeries and perioperative complications of the surgeries, increased sympathetic drive, and metabolic causes like thyroid dysfunction. Both hypothyroid patients and hyperthyroid both can present you with precipitation of acute heart failure. Adrenal dysfunctions, pregnancies, peripartum related abnormalities, and the mechanical causes like myocardial rupture during acute MIs, chest trauma or cardiac interventions, acute native or prosthetic valve incompetence, endocarditis, all of these can present you with acute heart failures. Yes, we have this constellation of pulmonary edema. All of them can contribute. Even some patients can present to you with the BP of 240 by 120, like hypertensive heart failure. Some patients can develop, present with you acute coronary syndromes. Then acutely decompensated chronic heart failure, which is the most commonly presenting one. And patient can land with cardiogenic shocks. Clinically, patients of acute heart failure has been divided into 4 types, depending on the congestion and the perfusion. If the patient is having no perfusion and no congestion, that is called warm dry. And if the patient is having hypoperfusion and no congestion, that is called cold dry heart failure. And if the patient is having no hypoperfusion, but there is congestion, so the patient will be warm and wet, means he will be having edematous, raised GVP, crackles in the chest, but the BP will be normal, the peripheral pulses will be normal, extremities will be normal, not cold. And then if the patient is having hypoperfusion, like cold, sweaty extremities, oliguria, mental confusion, dizziness, narrow pulse pressure, and still also there is congestion, so this will be the cold and wet. So we come across mostly warm wet and the cold wet. Symptoms: dyspnea, breathlessness, fatigue, orthopnea, cough, weight gain, ankle swelling, and signs like tachypnea, tachycardia, low or normal blood pressure, raised GVP. We can also hear auscultate the third and fourth heart sounds. There may be rales, crackles in the chest, edema, and intolerance of the supine position. Patient complaint will be that he can't lie supine. That means he is having orthopnea. And some patient will be saying that last night I couldn't sleep. I had started a good sleep, but then I developed this shortness of breath. I had to get up again and again because of shortness of breath. Cardiovascular risk profile, we already we have studied that older age patients are more at risk. Hypertensive patients, patients having diabetes, those who are smokers, family history of dyslipidemias or the patient having dyslipidemias, family history of coronary artery disease, and history of cardiovascular disease of the patient who has presented. Precipitants, already in the last slide we discussed that precipitants are a lot, even the arrhythmias are stopping the drugs. Differential diagnosis, the first lecture which we just listened, so the patient can have the differential diagnosis of septic shock, severe anemias, acute respiratory distress syndrome, and nowadays you will be also confusing heart failure patients with the exacerbation of obstructive pulmonary diseases. So we see a patient with suspected acute heart failure, rule out cardiogenic shock, look at the BP, etc., and rule out respiratory failure. If there is cardiogenic shock, circulatory support is needed. If there is respiratory failure, respiratory support is needed. Then in the next 1 to 2 hours, you will be identifying the causes, the acute etiology, which is the CHAMP, coronary syndromes, hypertension emergency, arrhythmias, mechanical cause, and pulmonary embolism. If yes, immediate specific action is to be taken, and then the diagnostic workup of to confirm acute heart failure. And in the diagnosis, we need the investigation like CBC, the serum electrolytes, and the one which is mostly done is the BNP. A raised BNP more than 300 is diagnostic of heart failure. and less than 100 almost rules it out. So, on the clinical presentations, you diagnose the patient with acute heart failure, bedside assessment to identify the hemodynamic profiles. Then we have presence of congestion. If yes, which most of the patients are there, 95%. Now, so look, in the start we said that this patient can be wet and dry, wet and warm, or wet and cold. So if the patient is wet, means edematous patients, and warm, what you will be doing? You will be, there will be vascular type fluid redistribution, hypertension predominates, so you need vasodilator and diuretic therapies. And if the patient is having adequate peripheral perfusion, no adequate peripheral perfusion, then diuretics, vasodilators, and sometimes if the patient is diuretic resistant, proven diuretic resistance, then ultrafiltration is needed. But if the patient is dry and warm, adequately perfused, it means if it is warm, so it means perfusion is okay. So adjust the oral therapy only. And if the patient is dry and cold, means the patient is hypoperfused. So consider fluid challenge. And if the patient is not responding to the fluid challenge, then we can consider inotropic support. So the classes of recommendations, class 1 recommendations are heart failure patient hospitalized with fluid overload should be treated with intravenous diuretics. And if somebody is already on oral diuretics, you will be giving equal dose or more than the equal dose of the same type of diuretics in the intravenous form. Heart failure with reduced ejection fraction patients requiring heart failure hospitalization who are on guideline-directed medical therapy should be continue the same dose unless hemodynamic stability is there or the drug is contraindicated. Initiation of beta blocker therapy at low dose is recommended after optimization of volume, status, and discontinuation of intravenous agents. Thromboembolism prophylaxis should be started for the hospitalized patient presenting with acute heart failure. Serum electrolytes, urea nitrogen, creatinine, and BNP should be measured during the titration of heart failure medications, including the diuretics. Then we have class 2 recommendations for the management of hospitalized heart failures. When diuresis is inadequate, it is reasonable to give higher doses or add a second diuretic, like if already on the loop diuretics, you can add a thiazide also. But these are the class 2 recommendations. Low dose dopamine infusion may be considered with loop diuretics to improve the diuresis. Ultrafiltration should be considered in patients with obvious volume overload and who are already has been on the maximal diuretics and they are having diuretic resistance. Ultrafiltration may be considered for patients with refractory congestion. Intravenous nitroglycerine, nitroprusside, or nisiritide may be considered as an adjuvant therapy. In patients hospitalized with volume overload and severe hyponatremia, vasopressin antagonists like the tolvaptan and conivaptan may be used. So these are the drugs which, according to the patient clinical condition, if already the patient is on the same drugs, you will be considering whether to stop them or not. In the case of AC inhibitors, if the patient is having normotension or hypertension, you may review or increase the dose. Beta blockers, so these are the clinical scenarios in which the patient, if present, you will be, according to the contraindications are in the same clinical indications. For example, in a hypotensive patients or NYHA class 4 patients, you will be stopping the beta blockers. So shock, a momentary pause in the act of death. मुझे ये definition बहुत अच्छी लगी shock की वजह से. If the cause is the heart, so this is the cardiogenic shock. If the patient, you have been given the maximal therapy, medical therapy, then you can consider the mechanical cardiac devices like intra-aortic balloon, ampellas, tandem heart, levitrox, and even the extracorporeal membranous oxygenations. So last two slides. What are to be done? After offer intravenous diuretic therapy to the people with acute heart failure. For people already taking diuretic therapy, consider a higher dose of diuretic than that on which the patient is already using. Closely monitor the person's renal function, weight, and urine output during diuretic therapy. Consider inotropes or vasopressors in people with acute heart failure with potentially reversible cardiogenic shock. Administer these treatments in a cardiac care unit or at least in HDU. And the don'ts: do not routinely offer opiates unless and until the patient is in so severe uh, depression. Do not routinely offer nitrates to people with acute heart failure except concomitant myocardial ischemia, severe hypertension, or regurgitant aortic or mitral valve disease. Do not offer sodium nitroprusside to people with acute heart failure. Do not routinely offer inotropes or vasopressors to people with acute heart failure. Yes, when you give them the fluid challenge and they don't respond, then you can add. Consider inotropes or vasopressor in people with acute heart failure with potentially reversible cardiogenic shock. And do not routinely offer ultrafiltration to people with acute heart failure unless and until there is proven diuretic resistance. Do not routinely use non-invasive ventilations or non-invasive positive pressure ventilation in people with acute heart failure and cardiogenic pulmonary edemas. Thank you.